Hello, everybody, and welcome back to Psych 121. We're in Lecture 10 this week, Chapter 18, talking about the treatment of psychological disorders as well as why psychology matters. So, some objectives here for us today. We'll talk a little bit about 3 approaches to treating psychological disorders, which will include psychotherapy, biological and pharmacological treatments, and social interventions. We'll also discuss a little bit about what we know about what works for treating and preventing mental health disorders. And finally, we'll evaluate the case for why psychology is well suited to help ameliorate psychological distress. By way of beginning, I'd like to read our land acknowledgement today. So, as we engage in remote teaching and learning, I'd like to acknowledge that the Saskatoon campus of the University of Saskatchewan is on Treaty 6 territory and the homeland of the Métis. We pay our respect to the First Nations and Métis ancestors of this place and reaffirm our relationship with one another. I'd also like to recognize that some may be attending this course from other traditional Indigenous lands. I ask that you take a moment to make your own land acknowledgement to the peoples of those lands. In doing so, we're actively participating in reconciliation as we navigate our time in this course, learning and supporting each other. So, when it comes to treating psychological disorders, we tend to focus on either psychological, biological, or social approaches. So, the psychological approach really involves providing help to individuals or families through psychological therapy, or what we commonly refer to as talk therapy. Whereas the biological or the biomedical approach tends to use medications and brain intervention techniques, so more biologically based interventions. And finally, the social approach tends to focus on changing the social environment in which individuals live to reduce the underlying causes of disorder. Now, a clinician may focus on any or all of the 3 approaches to treatment, and the decision will really come down to what the empirical literature shows works best for a particular disorder. So, for example, what works well for treating depression does not necessarily equate to the same factors that work well for treating an eating disorder. And so, in order to have some of that flexibility to provide the best treatment, we need to be flexible in terms of what of these levels we focus on and whether or not we need all 3. So, when we talk about psychotherapy, all psychotherapy begins with a very thorough psychological assessment. So, a psychologist will begin by systematically learning about a patient's needs, will evaluate kind of their psychological, their mental health, their developmental history, their behavioral history, the presenting problem, the history of how the problem has been, how they've worked with it in the past, what they've done, what's helped, what hasn't helped. All of these things are important. In addition to that, we'll often use personality tests, projective tests, or other forms of information gathering. So, behavioral rating scales, self report, parent report, friend report, teacher report, any of these kind of things that can be helpful for us to formulate a very clear picture of who this person is and what's going on for them. In addition to that, in certain settings, we may also rely on using like a structured clinical interview. Everybody has a clinical interview, but there's people that there's various types, and so we may also rely on a very structured thing to ask questions in a very particular way in order to get the information that we need. Sometimes we'll do cognitive testing or other types of behavioral testing as a way to gather all the information so that we can make a recommendation for what the best treatment would be. Now, depending on the requirements of our particular position, workplace, as well as what the client needs, sometimes we may make a formal diagnosis using the DSM, so the Diagnostic and Statistical Manual of Mental Disorders. Now, as I've talked before in the last chapter, we have a love-hate relationship with the DSM, but at the same time, diagnosis can guide treatment in a way that can be very helpful. And so if we can specify the particular presentation or how it's kind of looking for this person, sometimes that diagnosis can be very helpful in determining what the best treatment would be. So the psychologist will then summarize the diagnostic information, and the diagnostic or the diagnosis will likely be sent to an insurance company to justify payment for the treatment if you're in private practice, or if you're like me working in public practice, we don't have to confer a diagnosis, but we may, especially if it warrants it and if there are demonstrable benefits for the client. After we've done this assessment and we've talked with the client or the patient about what we think is going on in their life, well, then we say, here's my recommendations. And in most cases, some of that recommendation will include psychotherapy. And so psychotherapy is a form of therapy that uses techniques that encourage communication of conflicts and the development of insight. Therapy includes assessing a patient's issues and problems. We plan a course of treatment, we set goals, we do the treatment itself, and we evaluate progress as we go on. Now, the common idea that most people have about therapy is that you're lying on a couch and somebody's sitting behind you and they say, "Tell me about your mother," and that is a type of therapy. It's psychoanalysis. It is still practiced, but it really is in the minority. In most places, we don't have couches anymore, and our therapies tend to look very different than what they are often stereotyped as in movies and shows. The textbook says there are over 400 different types of therapies. Other folks have counted that it's upwards of 1,000 at this point in time. So there are such a divergent amount of therapies, each of them targeting different things and looking very different from each other. Now, because this is an intro course, we still kind of do a little bit of the overview. So we've talked a little bit about Freud before, psychoanalysis. Well, Freud's psychoanalytic theory has led to psychodynamic therapy or psychoanalysis. And it's driven by Freudian and neo-Freudian personality theories. But basically, the main thrust of psychodynamic therapy is to help clients to develop insight. And so the analyst engages with the patient, and usually it's one-on-one sessions. The patient's lying on a couch facing away. The goal is for the patient to talk about their personal concerns, their anxieties, and it allows the therapist to understand what underlying or unconscious problems may be at work. And so some of the techniques that a psychodynamic theorist would use or therapist would use would be like free association. And so the client will just kind of talk about whatever comes to mind, and the associations will then kind of be explored as they're happening in the moment. Dream analysis is another big kind of technique used in this particular therapy, as well as interpretation. So the therapist really serves as an interpretive guide. So out of all of the free association, the dream analysis, the therapist really drives the understanding or the interpretation of what is happening for the client. So the main goal behind this type of therapy is what I said before. It's that to help a patient develop insight, which is an understanding of the unconscious causes of the symptoms. Now, we talked a little bit before about this idea that, the goal is to make the unconscious conscious. Now, given the fact as well that there's a high level of interpretation from the end of the therapist, patients can sometimes show resistance and engage in particular defense mechanisms to avoid the painful feelings in their unconscious. These types of sessions, and actually really any counseling sessions, may tend to lead to transference as well, which is when the patient unconsciously redirects feelings experienced in an important personal relationship toward the therapist. So, for example, if there's a very highly contentious relationship that they have, sometimes a client will bring that into the session and be combative with the therapist, even though the therapist isn't really the cause of that experience. Now, one of the main problems of traditional psychoanalysis is that sessions would, go on forever. So they'd occur like 2 to 3 times a week. They'd go on for years. They'd cost thousands and thousands of dollars. It was so much money. And so modern psychodynamic approaches have focused on how do we use shorter term, more focused and more goal-oriented approaches. And they've had some success in changing psychodynamic therapy into something that is just, briefer. Now that's one kind of type of therapy, or one school of therapy that you could rely on. Another very important school of therapy is the humanistic field. And humanistic psychology really kind of was born out as a bit of a reaction in the 1960s to pure behaviorism. And it emphasizes personal growth, resilience, and the achievement of human potential. So basically, it's based on the idea that people develop psychological problems when they're burdened by limits and the expectations that are placed on them. And a really big driving goal in humanistic therapies is emphasizing each person's capacity for self realization and self fulfillment, and the fact that people are driven towards self actualization. So, some important theorists for you to be aware of would be like Abraham Maslow and Carl Rogers. These were kind of these were really two big names in humanistic psychology that really developed the field. So I'll talk very briefly about them. So Maslow is well known for his hierarchy of needs. So he was a psychologist, and he also really studied this idea of self-actualization. And so he kind of created this idea that we're motivated to self-actualize, but before we can do that, certain basic conditions need to be met in our lives. So, for example, starting very at the bottom, unless our very basic physiological needs are satisfied, we can't even then begin to work up the ladder. So we got to start with the physiological stuff. Now, if that's kind of set, then we can kind of move to the safety level of, security of body, employment, resources, morality, the family, health, property, all that stuff. And then from there, once those needs are satisfied, then we can start talking about love and belonging and esteem. And finally, if we can kind of move through all these stages, we can get to the top where we really focus on self-actualization. And to be true, there is some really valuable evidence, for example, for Maslow's hierarchy of needs. So, for example, the Housing First initiative is really, to a large degree, proof that if we really want people to be able to deal with issues like addiction, if we don't allow them to have stable housing first, how are we even going to begin to deal with higher order things? And so, the whole Housing First initiative is really driven in large part um, by a conceptualization of Maslow's hierarchy of needs, and it's actually had quite a lot of success. So, anyways, throwing that in for free there. But yeah, Maslow. So Maslow is very, very important. Also, though, Carl Rogers. Carl Rogers is, in therapy world, probably, he's one of the top, well, definitely in the top 10, if not the top 5 important therapists, probably of all time. And he developed this idea of what we now know as person-centered therapy. And basically taking this humanistic philosophy, his therapy was set up to help a client grow and develop as the therapist provides a very comfortable and non-judgmental environment. So the goal of therapy is congruence. It's being okay with who you are, the good and the bad. And so, Carl Rogers saw that psychopathology is when there's a huge difference between our actual versus our ideal self. So the goal of therapy, therefore, is that we want to narrow that gap so that our actual and ideal selves are, one and the same. And the primary therapeutic mechanism, which is really the thing that was very bold and different that he did, was this idea of unconditional positive regard. And so that would be the therapist giving love or support to another person, to the client with no conditions attached. Okay? And if you want to watch Carl Rogers at work, take a look at that link. It is really a treat to see that we actually have video footage of how Rogers did his work. So one of the biggest values that we've kind of the biggest things that Rogers kind of left for us. He left us a few, but he really argued that therapy is most productive when the therapist created a positive relationship with the client. And because of his work, we developed an understanding of what we now know as the therapeutic alliance. And that's the relationship between a client and therapist. That's facilitated when a therapist is genuine, treats clients with unconditional positive regard, and develops empathy with the client. And I'm going to be honest with you, the therapeutic alliance is probably the most important factor in psychotherapy that actually propels change. And so if you ever do see a therapist or a counselor, psychologist, you want to make sure that you've got a high level of therapeutic alliance, because that is a large determinant of how well things will kind of go. And like I said there. Okay. So here was Rogers' kind of belief. So he said, if the following conditions exist, that there is a vulnerable or anxious client, that they contact a counselor who possesses congruence in the relationship, unconditional positive regard for the client, and empathic understanding for the client's internal frame of reference, and that the client perceives conditions 3, 4, and 5, what he kind of called the necessary and sufficient conditions for therapeutic growth, Then therapeutic change occurs, and the client will, one, become more congruent, less defensive, be more open to experiences, have a more realistic view of the world, develop positive self regard, narrow the gap between ideal self and real self, be less vulnerable to threat, become less anxious, take ownership of experiences, become more accepting of others, and become more congruent in their relationship with others. So a huge emphasis was placed on the therapist as person, and that the therapist as a person could really help by developing that unconditional positive regard to create kind of the petri dish, I guess, as such, for the client to actually be able to change and to grow. Now, at the same time that the humanistic folks were doing some stuff, a bunch of existentialists kind of rolled onto the scene here. And existentialism is a kind of a philosophical approach that emphasizes the inevitable dilemmas and challenges of human existence, the problem of existence. So, for example, one of the big aspects of existentialism is this idea of existential anxiety, or what Kierkegaard called angst, right? Which is the reality of our mortality, all right? And so existentialists would say, hey, we're gonna die. Each and every single one of us has an expiry date, and we will die. Um, and that the reality of death can be something that's crippling and can keep us from living fully. Or we could use that fact, the fact that we are going to die, as something that can propel us towards living bravely and courageously in our world in this moment of time. So, the best life that we can make for ourselves is the one that we can live courageously into the present that we have in front of us. And one of the big names in existentialism was Rollo May. And so there's another link there to see how Rollo May worked with people, because he was a very unique and very, very awesome therapist. Now, in our day and age, cognitive behavioral therapy has received probably the most, I guess, gold stars, or definitely the most fame. And part of the reason for this is a couple, but one of the things is because it really works in our world, in terms of how we kind of frame things. I mean, the cognitive aspect of stuff is very appealing to some people, so that's kind of one side of it. The other side too is that cognitive behavioral therapy, from the day that it started, was heavily focused on being research based and demonstrating its efficacy through research. And so, given the current paradigm that we're in, where we're looking for evidence-based treatments, cognitive behavioral therapy, or CBT, has really been positioned quite well to be successful because of its knowledge base that it was built on. CBT is, in general, very present-focused. It's a problem-solving kind of approach. And it's based on the belief that our thoughts, emotions, behaviors, and physical responses have a reciprocal relationship with each other. It's very strongly rooted in evidence-based practice and scientific evaluation. And the thing that's also been very nice about it is that, in general, CBT approaches follow a very standardized approach. So CBT therapies were some of the first where they would use manuals or very specific treatment protocols uh, for therapists for what to do and how to do it. So, for example, I deliver an anxiety a CBT-based anxiety program called Cool Kids, and Cool Kids is a manualized approach. And so, we do have manuals, and we use manuals, and we follow the manuals in a fairly kind of consistent fashion. Now, having said that, I mean, when I'm saying it's a manual-based approach, I'm not saying like we sit there and we read out of the manual and then we do exactly everything like that. But the manual is there to guide treatment so that we make sure that we're hitting the high notes. We're hitting all of the important points, teaching all of the important skills, the things that we know will actually benefit and lead to better outcomes for our clients. Now, if you're interested in kind of seeing what the structure of a CBT session looks like, you can click on that link. I'll tell you now, CBT sessions are very structured, and the reason for that is because it's present focused and problem solving based. We want to make sure that that's what we're doing, and that we spend a lot of time working directly on those things to get some solutions happening. Now, I'll just show you this because I think this is important. The CBT model is such that we say that, a situation happens, and then we see here at the bottom the interaction between thoughts, emotions, the physical sensations in our body, and then behavior. All of these things work together, and they work together in a meaningful kind of way for us. Not only that, you can begin with a thought, but thoughts may not necessarily lead to emotions. They could lead to behavior first, or it could lead to physical sensation, and all of these things are reciprocal and acting upon each other as well. So, some of the techniques that are super important in CBT would include becoming aware of automatic thoughts. So automatic thoughts are the things that go through our head, and they are split-second type of things that we don't even really think through. They just happen so quickly, and then we tend to respond to these types of thoughts very, very quickly. And so one of the things we do is we begin to help people to recognize these automatic thoughts. So for example, let's say for a very anxious person, they go to a social gathering, maybe they say hi really quietly and no one says hi back to them. And so then they might think to themselves, well, I'm a loser, everyone hates me. Okay, that right there, that I'm a loser, everyone hates me, that's an automatic thought. And so as a CBT therapist, I would then challenge that client to say, oh, okay, tell me about that. What's the evidence that you're a loser? And then we kind of work on beginning to become aware of that. Because if we can change that thought, even just a little bit, to say like, oh, maybe they didn't hear me, that leads to a better or a more adaptive response, doesn't it? So some of the ways that we help people become aware of these automatic thoughts is through journaling, reflecting, noting those strong emotions so that we can kind of help them to kind of pick up when they happen and become more aware of them. Because if we're aware of them, then we can respond to them. The other thing that we help people to do is to identify cognitive errors or unhelpful thinking styles. And these are kind of consistent errors in how we think about particular situations. And I mean, there's a whole bunch of them, but some of them would be like all or nothing thinking, catastrophizing, emotional reasoning, mind reading, should and must statements, and so forth. And all of these unhelpful thinking styles kind of lead us a little bit stuck. So, for example, all or nothing thinking in a university context could be like, unless my assignment is perfect, I'm not going to hand it in. Okay, well, that is a very rigid style of thinking, especially if this is a final project, right? So we want to help clients to identify those thinking errors, those unhelpful thinking styles, so that we can then help them to become a little bit more flexible in how they respond to problems, and perhaps let go of some of the underlying beliefs that aren't necessarily very helpful to them. Other things that we tend to do a lot in CBT include tracking mood, tracking sleep, helping clients to begin to engage in pleasant experiences again, particularly if they've been withdrawing or suffering from something like depression. So we would do like pleasurable activities scheduling or behavioral activation to kind of get them going and get them doing things again. Now, CBT is a mashup, right, of cognitive things as well as behavioral things, okay? And so within CBT, we can tend to focus a little bit more on the cognitive side of stuff or on the behavioral side of stuff. And so cognitive therapy, pure, really focuses on helping clients to identify incorrect or distorted beliefs that are contributing to disorder. And so the cognitive side of things is really when we're focusing on that changing our thinking, right? Now, two influential names in cognitive therapy are Aaron Beck, who just recently passed away at the ripe age of 100, as well as Albert Ellis. And both of these guys provided the basic principles for cognitive therapy. So, Albert Ellis developed rational emotive behavior therapy, or REBT. And the goal there is that we want to challenge and replace irrational thoughts with more rational ones. Now, Ellis was a very interesting guy because REBT tends to be, of the cognitive therapies, a little bit more combative than CBT. Um, and I should probably put a link in here to you so you could see how Albert Ellis would work with clients. But he was a lot more of the like, well, stop it. Stop thinking like that. Just change that thought, right? And for some people, that works really well. And then for others, that would not work so well. Um, Aaron Beck, though, tended to focus more, and initially actually exclusively on depression. And what Beck would do was set up experiments to have clients test their beliefs against life experience and against the actual evidence. And so, if you think of like Ellis, would be, in my mind, be like, stop it. Whereas Beck would be like, what's your evidence? All right, that was how he kind of framed all of his questions to people. Now, I kind of mentioned this, but there's also behavior therapy. And behavior therapy is based on the principles of learning. So, classical and operant conditioning, it's not covered in Psych 121. You're going to have to join me for Psych 120 for that, as well as behavior modification. So, for example, operant conditioning focuses on using reward or punishment, reinforcing behavior in order to teach new skills, and looking at kind of that observational learning, seeing what happens to other people, and that sometimes trains us for how we then respond. So, as a client practices new skills, appropriate behaviors are shaped through reinforcement, and this allows a client to manage complex situations. Now, one of the probably in my opinion, anyways, one of the cooler applications of behavior therapy would be something like parent-child interaction therapy. Now, parent-child interaction therapy, or PCIT, is not a purely behavioral therapy in and of itself. Like, it's not just pure behaviorism, but it is strongly influenced by behaviorism, and it's a great modality. It's an evidence-based treatment for behavioral problems in children between the ages of about 2 to 7. And one of the things that makes it very unique is that the therapist, instead of working directly with the child, is actually coaching the parent as they're busy interacting with the child. And so the way that it is done is that the therapist is outside of the room, either watching in through a one-way mirror and kind of live coaching a session that's going on, or it's done remotely, where the therapist would be communicating with the parent via kind of like a bud in the ear, like an earbud type of thing, or like a walkie-talkie type of system, and speaking directly only to the parent so that the child cannot hear, and then kind of teaching or telling the parent what to do. And what it really focuses on is, how do we teach parents to engage in positive reinforcement for their child's behavior? So it focuses on things like, how do we use praise appropriately? How do we reward appropriately? How do we ignore and engage in selective attention for negative behaviors? So it really focuses heavily initially on those behavioral principles. And then what also happens is it teaches parents how to use meaningful consequences and use extinction-based procedures for negative behaviors. So it is, even though it is a bit of a mashup of some other things too, including attachment, theory and some other, and play therapy, it really, really does a nice job of taking behaviorism and applying it in a very, very practical way for children with behavioral problems. So for young children with things like that tend to struggle with non-compliance, not listening, impulsivity, so things like ADHD or oppositional defiant disorder, all of those things, this works for really, really, really nicely. You can take a little bit more there at PCIT. Now, one of my favorite kinds of therapies is exposure therapy. Now, whenever you've got a disorder such as anxiety or phobia or obsessive compulsive disorder, then the goal of therapy is to reduce negative affective responses to a feared stimulus. And so exposure therapy is rooted very deeply in behaviorism, and it's based on the classical conditioning principle of extinction. So there are two different types of types of exposure therapy that we can use. One is called graduated exposure, and another one is called flooding. And I'll tell you a little bit about both of those in a minute. Now, exposure treatment can be carried out in real settings, so what we call in vivo, in the moment, or in imagined situations. Now, wherever possible, and whenever you're treating a disorder through exposure therapy, one of the most important things is that the exposure should be as real as possible to the actual feared object or response. So we want to make sure that we make it as real as possible, so we can actually kind of lead to that extinction-based thing. So graduated exposure or gradual exposure is when we gradually and slowly expose someone to a feared situation through hierarchies of fear-evoking events. Okay. Now, flooding, on the other hand, is when we take a client and we put them into the source of their fear and we leave them there until their anxiety begins to drop. Okay. So as you can imagine, most people are like, I'll do gradual exposure, because flooding is a very, very intense kind of thing. And so that can be a hard thing too, because then the problem is if you're using flooding to um, to to expose a client, then you have to keep the client in the feared situation long enough until their anxiety reduces enough and they realize that the bad thing that they're fearful of doesn't actually happen. So flooding leads to a little bit more of an unpredictable situation, whereas kind of gradual exposure is generally more acceptable to people and is a little bit more, it's easier to kind of manage on a clinical basis. So for flooding as well, what happens is the fear subsides as the client habituates while receiving some emotional support. It's quick, it's effective, but also we do know for flooding that a patient may or relapse after a short period of time. So here's an example of a gradual exposure. So for this young kiddo, for Ellie is quite afraid of dogs. And so in order to help Ellie to kind of begin to face this fear, for her, I mean, we got to start very low. So for her, step one on her hierarchy. So this is an example of a hierarchy. And so hierarchy is when we look at kind of the end goal of kind of, for example, step 10 there says to play in a yard with both dogs. Okay, so that's step 10. Perfect. But we kind of then say like, wow, Ellie's not there, and just making her go play in the yard with dogs when she's deathly afraid of them is going to lead to a significant problem. So in order to get to step 10, we actually got to go down all the way to step 1, and we got to slowly begin to expose Ellie to dogs. So step 1 for her, she just needs to start reading about dogs. And when she does that, then there's a reward attached for her. She's going to go walk with dad, okay? You can see on the right-hand side, too, there's this worry rating column. So if a client comes to me with a phobia about dogs, I'm going to get them to come up with worry ratings for me about different steps on their hierarchy. And so what we want to do is we want to start low, and then we want to work higher and higher and higher. And so what's going to happen with a gradual exposure is we're going to start with step 1, and we're going to do step 1 until kiddo is basically bored with step 1. And then from there, we're going to move up to step 2. So after Ellie's been reading about dogs, she's like, all right, I know lots about them. I'm bored with that. We're like, perfect. Let's move up to step 2. Oh, we're going to start watching some YouTube videos of dogs. Perfect. We're going to let her do that lots and lots and lots till that doesn't freak her out anymore, until she's kind of bored with that. And every time she does that, we're going to reward her because she's doing something brave, and we're going to keep building up from there. Okay, so that's an example there of how that would look. Now, there's another type of exposure therapy technique as well called systematic desensitization, and that's when we do kind of a step-by-step process of desensitizing a client to a feared object or experience, and it's based on counter-conditioning. So that's when we pair an incompatible response with a fearful stimulus, okay? So during this time, we're kind of helping to the client to also kind of learn how to relax at the same time. So this is different than the exposure that I just talked to you about, the gradual exposure. Because in the gradual exposure, we actually want the client to face that fear full on. We're not teaching them any relaxation or coping stuff. We're putting them in that thing and helping them to manage that fear. Whereas in systematic desensitization, we also kind of help to engage some relaxation stuff going on there. Okay, so again, in this thing, we also agree, we make a hierarchy of fears, and then we kind of confront them in a systematic manner. But again, here, not only that, so we've got we're going to think about the spider, but at the same time that we're thinking about the spider, we're also going to have some relaxation stuff. So it really should be like a 3-column kind of thing. We've got the behavior, the fear that it causes, and then the relaxation thing, the incompatible response we've got connected to it as well. Okay. Now, like I said, desensitization relies on counter-conditioning, which is when we're creating an incompatible response with a conditioned response. Now, behavior therapy works best when people, and exposure therapy works best when people directly experience that feared object. So in order to do that, and because there are so many different things we can't necessarily re-expose people to, so for example, for people who have experienced certain types of traumas or have experienced war or violence in those regards, one of the ways we can help to re-expose people is through using virtual reality. And this can sometimes be a very, very helpful way, especially to re-expose someone to conditions that that we can't recreate in the real world, and where just imagining it wouldn't be enough. So it's very common for people with PTSD, to help them to kind of return to that scene of trauma, and then kind of working with them on this counter conditioning. Now, another type of therapy that's also based out of behaviorism is what we call aversion therapy. And so that's when we apply positive punishment to reduce an undesirable behavior. And so that's when we're pairing an unpleasant stimulus with a harmful or a socially unacceptable behavior. So, for example, if you are trying to maybe kind of stop smoking, every time you think about it, boom, you're snapping an elastic band on your wrist. And so you're kind of pairing this kind of, the thought with an aversion or an aversive kind of punishment. Now, alcoholism has long been treated with aversion therapy. So, historically, people would be given nausea inducing drugs when they were craving alcohol during a detox state. Because the hope was here that, again, using classical conditioning processes, we are going to then kind of apply positive punishment. I guess this is technically operant conditioning, applying positive punishment when having a negative kind of thought attached to it. Now, the reality is, so while I'm talking about these discrete therapies, you might be thinking to yourself, okay, so people basically pick one thing and then that's kind of their thing. Well, the reality is that the most commonly practiced approach is what we call eclectic therapy. And that's when a therapist or a psychologist uses whichever techniques seem most useful and relevant for a given patient. So there are many different types of eclectic therapies. Dialectical behavior therapy is placed in here as an eclectic therapy. I would argue that it's not. It really is now kind of like a fourth wave of kind of the cognitive behavioral kind of approaches. But the goal is still kind of the same. With eclectic therapies, what we're trying to do is we're trying to pull from the techniques that we think are going to be most helpful for the client in that moment. So here's one of the things that's important to note, okay? There are multiple roads to treating any disorder, all right? But the type of therapy that's the best, because that's a question people ask often, which is the best therapy? The best therapy is the one that's going to work for the client. And so that's always should be the number one consideration. And so, more so than just getting a therapist who does CBT or who does narrative therapy or whatever, the goal really should be, am I getting the the person who's going to do the techniques that are going to be most helpful for me right now. So I'm going to pause here for now. We're going to pick it up in a minute, and we will talk a little bit about some of the biomedical or biological approaches to treating disorder.